Hello, everybody. We'll give everybody a few minutes to log on. We'll give it a few more minutes so people can log on, and then we'll get started about 5 after. Good morning to you, Kelsey. I think it's morning where you are. For me, it's actually nighttime. It's actually 9 o'clock. Oh my goodness, 4 a.m. That is dedication. The session is being recorded already. So it's about 5 after, so we'll go ahead and get started. So I'm Dr. Lapage. Tonight we are going to talk about childhood diseases, particularly gastrointestinal disorders of the children's and the infant. So upon completion of this presentation, y'all should be able to identify the pathophysiology, etiology, clinical features, diagnostics used, treatment options, complications, and then nursing interventions for cleft lip, cleft palate, lactose intolerance, celiac disease, and pyloric stenosis is what we're going to focus on tonight. We're hopefully going to be able to prioritize those nursing interventions that are required to treat these patients with the GI disorders, and then incorporate the pharmacological principles to administer medications to these patients. Don't forget our basics with medication administration, and then evaluate that care rendered for clients with GI disorders. So, we're going to go through the different disorders, and then we're going to do some practice questions. So the first disorder we're going to talk about is cleft lip and cleft palate. Excuse me. So they're both very common birth defects. They can be single sided, as you see in the one, or they can be both sides of the lips. And then the palate obviously is in the throat and or in the mouth, I'm sorry, the top part. And both are very common. Sometimes they accompany syndromes such as your Down syndrome and your Turner syndrome, some of your genetic disorders. The etiology is typically unknown, and surgery does leave a slight scarring, especially on the cleft lip. So, again, we also have to think of the psychosocial effects for both the parents and then the infant as that child grows older with that scar that's probably pretty visible in most times. The etiology is the deformity in the lips. How we kind of notice it is these babies start to have obviously the deformity you see first, but then it can lead to difficulties with swallowing, which would then result in difficulty eating and sucking on the bottle, especially the cleft palate. And then as they begin to age, then talking and
Hello,
forming.
Professor. You've not shared the slide.
I'm sorry?
I said you've not shared the slide for today's topic.
I have. Let me try again. Okay, can you see them now?
Yes, you can see it now. Thank you.
Okay. So, the nose and the lips in the normal gestation of a baby is going to form at 3 to 6 weeks. But what occurs is that lack of fusion among the lips and then in with the nasal passages when we talk about the palate. It's going to result in that cleft lip and or cleft palate. Most often you see both in most of your infants. They can be severe or it can be mild, a mild deformity or a very severe deformity. Your cleft lip is going to be more common in your males, and it can occur with or without the cleft palate. Whereas the cleft lip without the cleft palate is more common in your females and infants. So, what are your signs and symptoms? Well, at birth, they're going to see that deformity. It's going to be identified pretty immediate. Both of those are pretty severe, bilateral cleft lip and then the unilateral. And those are pretty severe. You can see that because there's no formation there. It is a split in the lip that affects one or both sides. It may extend to the upper lip and all the way into the gums. And then the split in the roof of the mouth typically is not visualized. But so then it would be a nurse's role, especially if you're working in labor and delivery or in the NICU, to then identify that, especially if these babies start to have difficulty with those first feedings. As they grow older, and we'll talk about when surgery is recommended, they cannot do surgery right away. So if these babies start to cry or get old enough to talk, they're going to sound very nasally, and that's because of those openings. These babies are more prone to frequent and constant ear infections. Think about it when they're starting to suction. I'm sorry, suck on the bottle or the breast, and they are having openings. They're not going to get a good suction. They're not going to be able to feed. They may be laying down more to try and get the formula in. And then liquids and food can come out of their nose, which is what we're going to see. So it can be pretty disturbing and pretty difficult to care for those. What are some of the complications if we're focusing kind of on feeding? What do you think would be a complication of a cleft lip or cleft palate? LPNs can attend as well. Are you not hearing me? Because I see somebody put no sound.
Aspiration.
Aspiration, choking. And then if they're not getting the fluids, I'm assuming y'all are hearing me because you're answering. If if they're not getting the formula or the breast milk in, they could wind up, yes, with dehydration. They could also wind up with malnutrition as well. Absolutely. Low birth weight. Absolutely. So that's going to factor into when they can have surgery. And we'll talk about when they can have surgery in just a few minutes. So, some of the risk factors for cleft lip and cleft palate, it's genetic. Another infant who's had a family history of it, if there was another child born with it, that is a risk factor. Tobacco and alcohol use in the mother during pregnancy, and also a decrease in the mother's folate level during pregnancy. So that's why good prenatal care is always good and should be taught to these mothers. We see it a lot with premature babies, and we see it a lot with babies born of very young mothers because they tend to not get that prenatal care. So, some complications, definitely that difficulty with feeding, which ultimately they're going to have difficulty with nutrition and then growth. Ear infections that can lead to hearing loss, especially with the cleft palate. They could have some dental problems because those teeth are not going to grow normal, speech difficulties, and then those psychosocial issues. So, what do we need to do to the pregnant or for the pregnant mom? Definitely help prevent it, and with a lot of education. Um, Making sure that they're getting good prenatal care, making sure that they're not drinking alcohol or smoking any type of tobacco products or inhaling tobacco products or even vaping during pregnancy, because we have to take that into consideration too. A lot of times people think that now the vaping in the US has become very popular. It just it's one of my pet peeves. I just don't think it's very ladylike to see somebody vaping. So I'm sorry if I offend anybody who vapes. I'm old school, but it also contains the nicotine as well. So a lot of times people, it's very hard for them to understand that yes, there is nicotine still in it and other substances too. So, how do we treat it? Basically, surgical repair is the only treatment. The cleft lip repairs, typically they wait till they're about 3 to 6 months of age. The cleft palate repair is going to be longer, typically 9 to 18 months. So think about, we really need to get these babies with good nutrition. Follow up surgeries, because they may need to have scar revisions or revisions of that cleft lip as they grow, are typically between 2 years and then in their late teen years, especially if it becomes that psychosocial and that image thing. Because think about when we talk about Erickson's stages of development and Maslow's hierarchy of needs, think about what is a teenager. They're not going to want any disfigurations. What's important to them? And then a Haberman feeder is it's a bottle, and you can see I put a picture of it there. It is a specialty bottle that helps them be able to suck and get the breastfeeding, or the obviously the mom would have to pump and put it in that bottle, or the formula to help with the growth of the baby. So, one of the indicators for surgery is we use the rule of tens for that cleft lip and palate repair. The infant needs to weigh 10 pounds or more. The infant needs to be 10 weeks or older. They need to have a hemoglobin of at least 10 grams per liter. And then they need to have a white count that's under 10,000. So that's your rule of tens. That might be something. NCLEX loves the signs and the rules when we talk about rule of nines, when we talked about burns a little. So I would probably commit this to memory, the rule of tens for cleft lip and palate repair. So it's an infant who weighs 10 pounds or more. They need to be 10 weeks or older. They need to have a hemoglobin of at least 10 and a white count less than 10,000. Does anybody have any questions? So I see somebody put in here proper take care of post-surgical. So what do you think might be a post-surgical intervention that the nurse is going to do? Because we're getting ready to talk about that. What are going to be some nursing interventions?
Prevent the baby to touch the site that they had the surgery on.
Yeah, that's going to be hard, right? How are we going to get
Yeah.
them to stop touching? Because what do babies want to do? They put everything in their mouth, right? What are
Mm-hmm.
we as the nurse going to focus on?
Do not let the baby cry.
Well, how are you going to do that, right?
Infection. Make sure they don't get any infection in that area.
Infection, aspiration too, because remember, we're doing surgery on the lip and the mouth, which is close to the airway, right? So, hand mitten restraints,
And the
absolutely.
position. What? The position.
Very good. The position of the baby. We want to keep the baby upright, right? Especially when they're feeding to prevent those ear infections. Good job.
And elbow restraints.
What kind of restraints?
Elbow.
Okay. So, preoperatively, we want to get a good physical assessment. We want to get a good nutritional assessment to make sure that they're meeting the rule of tens, right? So they need to be older than 10 weeks and more than 10 pounds. Get a good developmental assessment to see if there's any co syndromes or other disease processes associated with it. And then a family assessment. How are the parents handling this, right? Anybody who ever has a baby wants that perfect baby. And what happens when, there's deformities or there's illness? That can weigh heavily on the family. So get a good family assessment. Who's there? How are they coping with it? And are they able to care for this baby afterwards? And then monitor how they're bonding with that baby as well. And then you want to evaluate any educational needs. We're talking about the infant, but remember the family is also the patient as well. So, post-operatively, good oral cavity assessment and making sure that we're doing good oral hygiene on this baby. Definitely prevent infection, like we talked about, monitor their respiratory status, and then assess for any of those psychosocial issues. And this is going to be an ongoing assessment, especially as they age, because the children are then going to become school age. They're going to wind up having peer pressure and all of the things that go along with aging. So, making sure that they're getting those good follow up cares and those assessments throughout their lifespan. Does anybody have any questions on cleft lip and cleft palate before we move on? Psychosocial needs for the family, absolutely.
So when it comes to them, right, for post-op surgery, do we do the least invasive to the most invasive with them? So like one of the guy here mentioned the elbow restraint, but I think I came across a question where they was saying that I think they had like books or something or paint the room blue. I don't remember what the question was. So do we pick the color to distract the child or do we put the elbow restraint on them to prevent them to touch the
So I think it's gonna depend on what's in the question. What was the correct answer on the question you had?
I don't remember, but the child was 2. So but I was stuck between pulling the elbow restraint on the baby or painting the room blue to distract them. So I was trying
Right,
to do the least invasive to the most
right,
invasive. Yeah.
right. So we think about if you try to restrain a 2-year-old, what's going to happen to that baby? Number one, they're going to get mad. And how long can you restrain them for, right? So you want to do distraction. If you're going to put mittens on them, you might be able to do mittens or get little gloves for the baby, right? We want to do the least invasive. We try not to do restraints because really it's restraining a patient and we don't want to do that. So I would have gone with distraction as well. um Elbow restraints, they may need those if they're intubated or they have to remain with the ET tube for their airway because we don't want them to pull that out. But I would not go with restraints. That's a lot of paperwork on the nurse's part and a lot of JACO, which is our governing body here in the US. They frown on restraint use, and likely so because we're restraining the patient. We are not letting them move freely, and we're not doing it requires a lot more frequent assessments, and it is one of the core measures with JACO. Restraint is the last option, yes. What's the rationale why infants need to weigh 10 pounds or more for cleft lip repair? Because they're growing and they're healthier. Remember, infants, if they're having surgery, this is more of a cosmetic surgery and to prevent malnutrition. So we're trying to get that baby healthy to begin with. Good questions. Any other questions? All right, so let's move on to lactose intolerance. So, what is it? It's the inability to digest lactose or those milk products, which is a lot of dairy products, right? These babies and children are not able to absorb that lactose, and it results in a malabsorption process. It occurs more commonly in American Indians, Asian Americans, Hispanics, and African Americans as well. So the pathophysiology, remember lactose is a disaccharide and it's present in milk and a lot of processed food. Dairy intolerance must be hydrolyzed, or the dietary lactose is then hydrolyzed to a monosaccharide and absorbed in the intestinal mucosa. In patients with lactose intolerance, its unabsorbed lactose causes increased secretions that's going to lead to electrolyte imbalances, dilation of the intestines, which is going to increase that small intestine transit, which is then going to increase GI symptoms such as diarrhea, pain, and then that malabsorption. It increases that degree of maldigestion of the lactose. lactose. Then free lactose remains fermented in the large intestine, which can cause those GI symptoms as well. So a lot of times these patients develop a lot of pain and cramping with diarrhea, sometimes some constipation. These babies, what's the first thing we give babies? Milk, right? So that's where we see that they're not digesting it, and they're cranky and they're irritable and they're crying, and every time we feed them they're getting worse. So we kind of identify these early on. There are 3 different types, which is the congenital or that autosomal recessive trait, which is very rare. The primary lactose intolerance is due to low levels of lactase, and we typically see those once they hit childhood age. And then that secondary acquired is that lactase deficiency is going to develop during or post an acute illness, such as any of your disease processes, common viruses, sometimes after as something as mild as an ear infection. Secondary lactose intolerance can cause acute gastroenteritis. It can lead to Crohn's disease, celiac sprue, which then they have an intolerance to wheat and barley, and we'll talk about that in a few minutes as well. It can cause radiation enteritis, some diabetic issues, and gastroapathy. May develop the Whipple syndrome. Sometimes chemotherapy can cause lactose intolerance, and then HIV enteropathy. Complications, it's typically not legal and lethal. I'm sorry, I said legal instead of lethal. Does have a low morbidity rate, but it can lead to osteopenia because of that vitamin D that these patients are missing with the lactose that they get and the dairy products. Some clinical features are going to be abdominal symptoms, GI symptoms, that bloating, cramping, pain, nausea, vomiting, symptoms of irritable bowel syndrome, which is either the diarrhea, the cramping, the pain, or the constipation. Or they could eat it one time and it causes diarrhea, the next time it's going to cause that constipation. It can often lead to comorbid conditions, some vitamin D deficiency, some anemia as well. Any questions so far? So, diagnostics. How do we diagnose it? Well, they're going to do a lactose tolerance test where they measure the cereal glucose levels after the patient has ingested a larger amount of lactose. They get a fasting serum glucose, and then they get one every 50 grams of lactose that they ingest. It is, and then they'll do levels at 0, 60 minutes, and then 120 minutes, which is going to be 2 hours. They do that milk tolerance test where they administer 500 mLs of milk and the baby drinks it or child drinks it. And then they do blood glucose levels as well. Imaging studies, that's not really going to be helpful to diagnose the lactase intolerance or lactose intolerance, but it will be able to rule out other things and other structural issues. They can do a breath hydrogen test. They can do dietary elimination. Take a food diary and eliminate dairy products and then introduce them slowly and see if the symptoms are there or they reside once the patient no longer is taking in those milk products. Small bowel biopsy may be done. With a small bowel biopsy, they need to do a colonoscopy on the patient and then take that biopsy. They may do some stomach biopsies as well, and that would be through the upper endoscopy. And then diet, again, that goes with that dietary elimination. Assess the diet, what are they taking, and assess it in relation to when they're having symptoms or not having symptoms. So, how do we treat it? Did somebody have a question? What is the hallmark clinical feature for this condition for lactose intolerance? It's going to be they're going to have the abdominal symptoms after they ingest something that contains lactose, which is going to be your dairy products. The biggest treatment, there's no real surgery for this. It's going to be dietary elimination, and they can take some lactase enzymes. There are plenty out there on the market, Lactaid, a bunch of different ones. And what the action is it's going to break down that lactose. They still need to watch the amount of dairy products that they ingest or foods that contain lactose. We use those lactase enzymes for lactose intolerance. There was no real contraindications that I could find. Generally, they are well tolerated. Y'all need to mute yourself, please. I've muted some people. Side effects, again, they're pretty well tolerated. I couldn't find any major side effects. There were some GI symptoms, but how do you tell if it's from the lactase or the lactose intolerance or the lactase enzymes? And then nursing interventions is going to be that dietary avoidance. How do we keep the patient away from lactose in the diet? Because it's in so many things. All the dairy products, right? Any questions on lactose intolerance? All right, let's move on to celiac disease. So think about both of these, lactose intolerance and celiac disease, both have they're both autoimmune. So patients can have both of those. So they're going to be very limited with the foods that they can eat. If they can't eat dairy products and then they can't eat gluten or wheat, barley, grains, or rye, they're going to be in a whole heap of trying to figure out what they can eat. Basically, fruits and vegetables, right? So, gluten is a protein that we find in grains. It's particularly found in wheat, barley, and rye. They, especially in our Western diet, we see it a lot in a lot of processed foods as well. So when gluten enters that small intestines, it triggers an immune response that results in GI upset. Much like that lactose intolerance, the symptoms are going to be very much the same. A lot of bloating, pain, abdominal pain, GI upset. They can have diarrhea, they can have constipation, they can have a lot of cramping. It's going to actually damage that mucosal lining in the intestines. So, again, avoidance therapy is going to be very important for these patients. After time and with the constant triggers or the immune response, it can then damage that lining of the small intestines. The etiology, we see it a lot in our Northern European descent. 1% of people in Europe and North America develop it. It can be hereditary and it can be caused by a gene variant. We see it more commonly in females, and we see it very commonly in patients with Down syndrome. So, our poor Down syndrome patients, get cleft lip, cleft palate, lactose intolerance, and celiac disease. We see it more so in Caucasians, and these patients tend to develop some comorbidities, particularly type 1 diabetes, juvenile rheumatoid arthritis, microscopic colitis, and then Addison's disease. So it's not one of those fun, I wouldn't say any disease is fun, but it's going to be a very limiting disease. I have a slide coming up of what celiac, or I'm sorry, what gluten is in, and it's pretty amazing. I used to work with a nurse who had very bad celiac disease, and I did not realize gluten is in soy sauce. So even though she could eat rice because that does not contain gluten, she wasn't able to eat the soy sauce, and some of the seasonings contain gluten. So, complications of celiac disease, malabsorption. These patients can get some systemic inflammatory diseases. They could get leaky gut, anemia, osteoporosis. It can lead to your GI cancers. Think about psychosocial wise. It could lead to depression because of isolation, and these patients typically can't go out to eat, or if they do, it's very plain food and they have to order it special. Can lead to a lot of neurological disorders and can increase the incidences of some of those neurological disorders, particularly epileptic seizures and some of your peripheral neuropathies. Migraine headaches can be a symptom if they're eating the gluten that can trigger or make the headaches worse. And then vertigo and ataxia. Unfortunately, celiac disease can lead to infertility, miscarriage, and then some congenital malformation in the pregnant women. Which food the client can able to eat, drink also. We'll talk about some of the foods. It's going to be a gluten-free diet. So we diagnose it with some blood tests. Again, they're going to rule out other disease processes. So we're going to see that CBC, make sure that everything is normal, the electrolytes, your blood glucose test. Often these patients, because remember we said they can have a comorbidity of type 1 diabetes, they may have some elevated glucose levels. Might need to do a globulin blood test and some of your IgEs and IgG antibodies for allergies and immune disorders. Your CRP is your C reactive protein. And if it's elevated, it shows that there's a sign of systemic inflammation. Your erythrocyte sedimentation rate, your ESR or SED rate for short, is another test that's going to reveal inflammation in the body. The levels are going to be elevated. They could do some blood smears where they actually examine the red and white blood cells under the microscope. Possibly might do some specific vitamin levels to see if there's deficiencies anywhere. And then an upper or lower endoscopy might be warranted. And then that's where how they would get biopsies to actually test for it. Treatment, again, is going to be your avoidance therapy, a gluten-free diet, vitamin supplements
So we need to assess.
according to what they're deficient in, and then just boosting their immune system and their nutritional
I
system.
changed it.
If it becomes very severe and they develop symptoms and those colitises, they may need to have corticosteroid treatments for short term and to help decrease that swelling and that inflammation, that systemic inflammation. The prognosis for these patients is typically good if they can eliminate the gluten. So our next slide is going to show you what gluten is in. It's in pretty much all processed foods, all of your packaged dinners, ice cream, soy sauce, any of your processed cheese or yogurt, hot and cold cereals, a lot of condiments, ketchup, mustard it's in. I'm not sure about relish, but I would assume so if it's in the others. Wheat, barley, rye, any of your malt liquors and your beers, soups, sauces, breads and baked goods. So it's everywhere, right? Years ago, a lot of patients started eating cauliflower pizza crust and cauliflower rice. So basically, these patients can eat meat as long as it's plain or cooked at home with no seasonings, and fruits and vegetables.
How about banana? Because they say banana also have.
I would not know about banana, but I would look at off the top of my head, I don't know about banana. I'm not sure why banana would fall under that category of wheat or barley. I can look it up real quick. So, according to the Celiac Society, it said bananas used to be the cure, or bananas were seen as the miracle food. So, I wouldn't say that they are excluded in it. According to this, they can eat. Yeah, this says the banana diet remains a common treatment for celiac disease. It doesn't say they need to avoid them.
Okay, thank you.
That came from the Celiac Society. Where were we? Okay. Any other questions? Food that contains gluten or BROW. Yep. Oh, geez. What happened there? Somebody put in the chat, foods that contain gluten are brow, BROW, barley, rye, oats, and wheat. Absolutely. What about oat? So the oats would be your hot and cold cereals. So, what are going to be some of our nursing interventions? Definitely a lot of supportive care, possibly get them in to see a dietitian or the parents in to see a dietitian for dietary management. A lot of support. There's a lot of support groups out there. Get them some information on support groups, possibly. Our interventions, as far as what we're going to assess, is going to be the GI function and then managing their symptoms or monitoring their symptoms before or after they eat something that they shouldn't. It's going to be a lot of times they're going to have pain, discomfort. They may need some over the counter stool softeners, just depending on what their symptoms are. And definitely manage their anxiety. So, again, think about as these children age and they're going to be out with friends, they're going to go out to eat, they're going to go to, get a pizza. They can't eat pizza, and are they going to kind of slip up? How are they going to manage it? How important is it to them? No, it'd have to be gluten free. What about oats? Pasta. So pasta is wheat, contains wheat, and no, they cannot have pasta. There's lots of gluten free pasta out there. They can have potatoes. They can have potato bread. There's lots of breads and rolls made out of potato. Some of your bakeries, we have a grocery store chain called Publix that will special order and make gluten-free bread for them, but you have to special order it. Um, a lot of specialty stores may have them. They use a lot of almond products and soy products as well. So, pyloric stenosis, what is it? Well, it's a narrowing of the opening between the stomach and the small intestines. It's going to trap food, and that muscle tissue becomes very enlarged. As you can see in the picture here, once it starts to trap food and it gets inflamed, it's going to cause that stenosis and that very narrowing. So the food is going to be difficult to pass through the intestines. We're going to see these patients start to develop weight loss. The hallmark sign of pyloric stenosis is that projectile vomiting because of the stenosis, the actual narrowing. It does require surgery. It is unknown causes, and it typically develops after the baby has been born and after birth. Some risk factors: male firstborn infants, premature babies, a family history of somebody else close having it, the mother smoked, and sometimes some antibiotic use in later trimesters can cause it. We see it a lot more in the bottle fed infants than we do in breastfed infants. Some complications are going to be that stunted growth and development, failure to grow. These babies can develop dehydration because of all the vomiting and the fact that they don't want to ingest anything because it hurts if it's not going anywhere, right? Jaundice, they do see, it is kind of rare, but they can see jaundice, especially when that bilirubin builds up, if it develops a stenosis or injury to the gallbladder and other areas. Signs and symptoms, again, that hallmark sign is going to be that projectile vomiting. These babies get very irritable after they eat, and it could be because of the pain of that food not going anywhere. These babies tend to get hungry immediately after they're eating, so they'll start crying. They're going to be a lot more lethargic and not want to move because obviously the pain. We're going to see a decreased urine output, so we monitor that. How do we really see that in an infant? We're going to see fewer diapers, fewer wet diapers. they're losing weight or not gaining weight. And then stomach contractions. When we talk about the stomach contractions, we're going to actually see the stomach contracting, and that's because it's getting stuck in that stenosis area or stenotic area. And then you'll see changes in bowel movements and in the stools. We diagnose it with an abdominal ultrasound. They can actually visualize that stenotic area. Abdominal x-rays may show. Serum lab, we're going to do the routine CBC CMP. They're going to do a bilirubin, especially if they assess jaundice. Get good electrolytes and liver function tests as well. What do you think the treatment is for pyloric stenosis? It's going to be surgery. That's about the only way to repair it. The changes in the stool and diarrhea or constipation, yes, or the amount of stool as well, or they're going to be very thin stools. What is CMP? A CMP is a complete metabolic profile where you get all your electrolytes and your liver function. It's blood work. So the treatment is a pyloromyotomy. These patients pre-op, we need to get them well hydrated for a good 24 to 48 hours prior to the surgery. What they do is they put an incision and they repair it that way. Post-operatively, we're definitely going to monitor them for 24 to 48 hours. We typically want to begin feedings with 12 hours. Within 12 hours. And then try to help the parents to develop a good feeding schedule. These babies or kids should have 3 small meals a day, or frequent small meals per day. Explain to the parents, you may see some vomiting immediately post-op. If it becomes projectile, or these patients tend to have irritability, same symptoms as before surgery, they definitely need to be reevaluated. And then monitor their growth and weight. There are very rare surgical complications, but there is a chance of bleeding, so we would definitely need to monitor these babies, especially their vital signs as well. And the same type of assessments, good GI assessments, that we do on any post-op patient. Does anybody have any questions before we do some practice questions? So I think back previously somebody asked what was Whipple disease, and that's a bacterial infection that is going to affect the digestive system. It's also like a malabsorption where they're not able to absorb fats and carbohydrates. Why does feeding begin within 12 hours? Because we want to, number one, keep this baby hydrated, and also assess whether the surgery has been successful or not. All right. So the more that you read, the more things you will know. The more you learn, the more places you'll go. Any questions on any of this stuff that we've gone over? All right. So let's take a look at a case study. So NCLEX has started putting case studies in their exams where they're giving you a patient, and basically if you view it as you're taking care of this patient, this is your patient you're taking care of for the day. Most of the time it's going to be bits and pieces of one day, or it's going to be bits and pieces of several days. And then they're going to ask a series of 4 to 6 questions, all related to the nursing process. Like the first question may ask you to recognize cues of a certain disease process found in that case study. So if you kind of look at it like, this is my patient, this is my day at work, it would really be helpful because you're putting yourself in that scenario. Some of the other questions that they may ask are about planning your care. So that's the planning stage of the nursing process. Maybe possibly about what interventions are you going to do for whatever disease process they're talking about. And then they may ask you to evaluate by looking at normal lab work, or comparing 2 days worth of lab work, or comparing the patient's condition from day 1 to discharge, and what do you see that has improved or deteriorated. And it could be any number of things. So putting yourself in, actually in the healthcare setting, and thinking of it that way is going to be really helpful. So a nurse in the newborn unit is caring for a 1-day-old neonate. So day 1 of life at 8 a.m., the nurse notes the newborn delivered via spontaneous vaginal delivery at 39 weeks gestation. APGAR scores 8 at 1 minute and 9 at 5 minutes. The infant exhibits difficulty latching and has nasal regurgitation of milk. So when you read that, what do you think of? Let's kind of pick it apart. So it's day 1. The newborn delivered spontaneous vaginal delivery. That's okay. Nothing wrong with that, right? 39 weeks gestation. His APSCOR scores were pretty decent. And he's having difficulty latching and nasal regurgitation. So let's look at our physical findings. Neurologically, he's alert, active, good tone, strong cry. So ask yourself, is there anything wrong with that? Anybody evaluate any difficulties? Okay. Unilateral right cleft lip extending into the palate. No other craniofacial abnormalities noted, and his nares are patent. Respiratory wise, he's got clear breath sounds bilaterally, no retractions or grunting. Cardiovascular wise, he's got normal heart sounds, no murmurs, and his cap refill is less than 2 seconds. So all normal. His abdomen is soft, non-distended, no organ megaly. That's good. Skin warm, pink, no rashes or jaundice. So that's good. And his extremities are well formed with normal spontaneous movement. So that's good too, right? Let's take a look at his vital signs. Does anything concern you?
No.
Okay. How about his medical history? Anything in his history concern you?
How about the weight? Like 7.5 pounds?
Nicotine
How about
use. Nicotine use.
nicotine use?
And rubella vaccine, 10-year gestational.
Yep, that could be it. Yep. Which of the following findings are likely the predisposing factors to the client's condition? So this is a select all that apply. So remember, you need to find which ones are going to contribute to it. We know it's a select all that apply because there's more than 4 answer choices, and select all that apply is bolded.
C, F, and I don't know if it has anything to do with the hypertension medication, methyl-dopa.
No, the mom can take methyl-dopa.
Okay, so I would say C and F.
So actually, it's missing one thing here. I'm sorry, I didn't catch that.
How about D? They have
A should be the rubella infection. And not, it should not say medical history. Somehow I typed it incorrectly. I'm sorry. A should say rubella history or rubella infection.
Mm-hmm.
So your answer choices are going to be A, pretending that that's rubella infection, and F, which is your family history of the maternal nicotine. She can be on hypertensive meds. I'll think about moms who get pregnant that have hypertension, or also if they develop preeclampsia, they need to be on hypertension medications. So, full term infant, she's 7 pounds. That's not bad. The mother managed for rubella at 10 weeks. That's gonna be that's gonna be your answer choice, and then the history of nicotine use places them at risk. So the nurse reviews the client's medical record. For each potential provider's order, identify whether it is indicated or not indicated. Should we assess the daily caloric intake? Is that going to be indicated or not indicated?
Yes, because now if the child has a lift, then they may not be able to intake enough calories than required for developmental stage.
Exactly. It is. It is indicated. We need to make sure because we know these babies with cleft lip and cleft palate are at risk for malnutrition and feeding and inadequate consumption and also dehydration. So it's definitely indicated. Prepare the child for immediate closure of the defect.
Indicated.
It's
No,
indicated.
Not indicated.
not
Not
indicated.
indicated. Right. Why is it not indicated?
The 10 rule.
Clearly.
Patient is not up to 10 weeks
Yep.
yet.
Yep. He's not 10 weeks
10
and
pounds.
he's not 10 pounds.
Yeah.
We don't have information about his white count or his hemoglobin, but we know he's got to meet all 4 of those. So he didn't meet 2 so far, so it's not indicated. Good. Keep a bulb syringe at the bedside.
Indicated.
Yeah, why are we going to keep
Indicated.
that bulb syringe at the bedside?
Aspiration.
In case of any
Aspiration.
aspiration.
Yep, it's the aspirate. Discourage frequent burping.
Not
Not
indicated.
indicated.
Right. It's actually encouraged. You're correct. It is not indicated because it says discourage. We actually encourage frequent burping to decrease the risk of regurgitation or vomiting and discomfort. And then initiate feeding using a Haberman feeder.
Indicated.
Indicated. Yep. Yep. There you go. Good job, guys. So at 8:30, your provider orders to be notified the pediatric plastic surgery team, initiate alternative feeding using the Haberman feeder, monitor weight, caloric intake, and hydration status closely, educate parents on feeding techniques and the importance of follow-up care, and then schedule outpatient follow-up with CLEF team at 2 weeks of age. So the caregiver is concerned and asks when the child's surgical repair will be conducted. The nurse understands that the cleft lip should be repaired at, we're going to look at option 1. So if you were actually doing NCLEX, this would be a drop down box with those options. So what do you all think for the first answer choice?
3 months.
3 months, absolutely. And the cleft palate will be done when?
6 months.
6 months.
No, 12 months, I mean.
12 months.
5
yeah.
months.
So the answer is 3 months and 12 months.
Can we go a slide before this one, please? Thank you. Okay, 2 weeks. Yeah.
So day 2, your nurse's notes at 0800 hours. The infant is tolerating feeds with the specialized bottle. The parents are educated on feeding techniques and signs of aspiration. The patient's weight is stable. There's no signs of respiratory distress. Pediatric plastic surgical team consulted with the tentative surgical repair planned for cleft lip at 3 months and cleft palate at 12 months. The parents demonstrate understanding of home care instructions, and they're discharged home with follow-up scheduled in 2 weeks. 3 months follow-up, you get a nurse's notes. The infant is admitted for scheduled cleft lip repair. The current weight is 10 pounds, 6 ounces, or 10.6. No recent illnesses. You see his vital signs. Anything concerning?
The weight, I think.
The weight is okay.
The weight? Why the weight?
I think at 3 months he's supposed to have doubled his weight.
The weight is fine.
in order to have this surgery, he needs to be at least 10 pounds.
10 pounds.
Yeah.
Respiratory rate.
Okay.
The nurse is preparing the child for cleft lip repair surgery. Which of the following actions should the nurse perform? And this is another select all that apply question. So there's more than one answer choice. That's correct.
Informed and absent consent to be formed. Maintain the infant nil oral before the surgery. Yes. Prepare the surgical site by cleaning it with antibiotic. Yes. Administer. No, no, it.
So what are our correct answers?
A, B, D, and F.
Okay. So is it the nurse's responsibility to obtain an informed consent from the caregiver?
No, the doctor. But
No,
No,
the
the
doctor.
nurse
Doctor.
witness.
We witness.
Yes, we witness. So it's not going to be A. Maintain the infant nil per oral for 6 hours before the procedure as ordered. Is that correct?
Yes.
Yes.
Yes. So for adults, it's typically 8 hours, but for infants, it's going to be less because they need to feed. Prepare the surgical site by cleansing it with an antiseptic.
Yes.
No.
No.
No, that's not. We're not going to cleanse it. He's going to go in the OR and he's going to get a very sterile cleansing, right?
Yeah.
Administer IV ceftriaxone as ordered.
Yes.
Yes, because we want to prevent that infection, right?
Yeah.
And think about it, the mouth is one of the most dirtiest areas on the body. Isolate the infant from the caregiver 1 hour to the procedure.
No.
No, we're not going to isolate them. If that's my baby, I'm probably walking that baby back there, right?
Mhm.
Check for any allergies to medication and latex.
Yes.
Yes. So your answers are B, D, and F. So at 0800 hours, NPO status maintained since midnight. Administer D5 half normal saline at 19 mLs per hour. Administer IV ceftriaxone 240 milligrams stat. Obtain a baseline CBC and electrolytes, and parental consent confirmed for surgery. So, why are we administering the D5 half?
To prevent low glucose level.
Prevent
Right.
hypoglycemia.
Yeah, because babies lose glucose, right? And they need glucose. So we're giving them the D5 half. Why this ceftriaxone?
To prevent infection.
To prevent
Infection, absolutely. Why are we getting the CBC and electrolytes?
To ensure that the HB is optimum.
Infection also.
Exactly, to make sure that his hemoglobin is 10 or greater, and electrolytes to make sure that we're not going to have any complications,
Right,
and
to
that he's
prevent
well hydrated.
dehydration.
Yep. So, what do you notice about the labs? Anything abnormal?
No, I'm not seeing any.
So, what two indicators do we need to look at for our rules of tens?
White blood cells and white blood cells.
hemoglobin.
Okay, so our hemoglobin is what? What do you evaluate? It's greater than 10.
But we have 13 now. It's okay.
Ensure that it is higher than 10.
Yeah. And the WBCs need to be where?
10,000, but it's just 8,000.
Between 8.5 to 12 thereabouts.
So have we met all four criteria for those rule of tens?
No.
Yes.
Yes, we did.
Yes.
Yes, we did. His hemoglobin is 10 or greater. His white count is 10 or less. He's 10 weeks. And he's more than 10 pounds, right?
Yeah.
He's older than 10 weeks because he's 3 months old. And he was greater than 10 pounds. So he's met all the criteria. He can have the surgery. So at 1100 hours, his cleft lip repair was performed under general anesthesia without complications. There was minimal blood loss. Postoperative sutures are placed with dissolvable material. He was extubated in the operating room and transferred to the recovery in stable condition. Anything abnormal there?
No.
No.
So, did we do a good job with monitoring this patient?
Yeah.
Did we do a good job?
Yes.
Yes, we
Yes.
did. We kept him
Yeah.
alive. It's fine. Yeah, we did a great job.
You did a great job. I like that positivity. Yep. The nurse is caring for the child post-operative. Which of the following orders should the nurse anticipate? Again, it's a select all that apply.
Yeah, but that's something that is.
What are we thinking?
D, E, F.
So A is in it. E and F.
Okay, so let's go through them. Place the child in the right side lying position. There's no, we should lift him, we should have his head a bed elevated, not side lying. So that's
Okay,
incorrect.
that's true. Outright.
Ma'am? That's A is incorrect.
Yes.
Apply an anti-infective ointment on the surgical site.
No.
Why not?
Yes.
Yes, we're going to do that. We want to prevent that infection, right? So we're going to keep that area clean and moist, right? Obtain
So
an
even
order.
if it's on the mouth,
Ma'am?
even if it's on the mouth, you still put the ointment there?
Even if it's what?
On the mouth, the lip.
Yes. We can put an anti-infective ointment on there. It's going to be above the lip. Obtain an
I'm sorry, what's the right position for the child?
Lying on their back,
Polar.
head of the bed elevated.
and they'll be on their back, right? Lying on their back.
Supine?
Yes. Well, supine is lying flat, head of the bed elevated with their head
Semi-polar.
up. There's no the point is there's no he should have the head of the bed elevated, but there's no reason for him to be right side lying. That's going to increase the risk of those sutures coming apart. We want to keep his head elevated. We can apply that anti-infective ointment, especially bacitracin can go on the face. So B is correct. Obtain an order for wrist restraints?
No.
Yes.
No.
Yes. No?
Why? Why are we going to restrain this child?
Because like if they go on pulling on or like
How long are you going to restrain this child for?
Not throughout. Like you'll have a breakthrough restraint. I feel like.
Yeah,
No,
no, we're not gonna. We have to take into consideration. He's 10 months. He's 12. He's 3 months old,
3 months.
right?
Mm-hmm.
He's gonna need to move around. We're just gonna have to be very diligent as the nurse and educate the parents who are probably going to be at the bedside to not let him touch the suture area. But we're not going to restrain this baby unless he needs it. Just because they have surgery and we don't want them to touch a surgical site is not a reason to restrain them. So we're not going to restrain them.
If this baby was 10 months old, like who is like more active kind of, then in that kind of case, like we use this or not? How do you do?
So again, we may use some elbow extenders or elbow immobilizers, but
elbow.
We're
I'm
not
sorry,
just immobilizers, not restraints, just to keep that elbow straight to where they can't bend. But typically, we really do not use restraints because think about all the problems a restraint can cause, especially in a child. We don't, that's kind of like the last resort.
Professor,
Got it. I'm sorry. I'm sorry about
ATI,
the.
they say the elbow immobilizer is a restraint.
Yeah, they do say that is gonna be a restraint.
It is a form of
It's an
restraint.
ATI question, yes. And is elbow restraint?
It is a form of a restraint, but it's the least invasive. But I'm just referring back to the question of them asking, wouldn't we want to restrain them? We don't want to restrain them. If we need to immobilize them, we may put an elbow immobilizer, but most often we can help these children. It might be a little more need a little more diligence of the parents, but think about their age too. You don't want to restrain them. Tape adhesive strip securely to the child's cheek.
No.
So we may need to do that because we don't want that wound to dehisce. So that is a correct answer choice. We don't want that wound to start coming open and dehissing. So we may need to put some surgical strips on the cheek. Using normal saline to cleanse the suture line of serous sanguineous drainage.
Yes.
Yes. And monitor the child's vital signs hourly for the first 2 hours post-op.
Yes.
Supposed to be half hourly. Okay.
Yeah.
So our correct answer choices are B, D, and E. F is not correct because post-operatively we need to be monitoring this baby more frequently than every hour. Especially in the first 2 hours, it's typically every 15 minutes.
Okay.
So your answers are B, D, and E. So at 0800, the infant is awake and alert, mild swelling at the surgical site, no signs of infection or excessive bleeding, feeding resumed using the specialized bottle, and the baby's tolerating it well, and the parents are reassured and educated on suture care and pain management. Anything in there concern us?
Oh.
Mild swelling we expect, right?
Yeah.
Anything about the vital signs concern us? No, they're normal for his age. At 800 hours, day 3 post surgery, the infant is tolerating feedings well. Pain is controlled with oral acetaminophen. No signs of infection at the surgical site. The parents were provided detailed home care instructions, including feeding modifications and signs of complications. Follow up appointment confirmed with the plastic surgery team, and the infant was discharged home in stable condition. So the nurse understands that the child requires a multidisciplinary management team. The child should be referred to which of the following professionals?
Speech orthodontist.
Therapist.
Speech therapist.
Speech therapist and orthodontist.
So, a speech therapist, an orthodontist, and who?
Cardiologist.
Cardiologist.
Why a cardiologist?
How about endocrine?
Endocrinologist.
Why an endocrinologist?
Because it's the mouth and is it could affect the throat or something,
An endocrinologist deals with endocrine disorders like diabetes. Does this child have diabetes?
No.
No. And why
So
a
would the speech
cardiologist?
affect the hearing?
Why a cardiologist? I heard somebody say cardiologist. So he doesn't need a cardiologist. So why would we send him to a speech therapist?
Because they have the
their speech would be affected.
Yes. Yes. Speech may be affected, and the oral structure had air flowing through it. So they probably weren't able to pronounce, or they're going to need help to pronouncing these words now that it's repaired. Does he need a chest physiotherapist?
No.
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 Does he need an orthodontist?
Yes.
Yes.
Yes. Probably needs an orthodontist. Yes. How about an audiologist?
No.
I would think so.
Yes. Remember, they're frequently prone
Hearing.
to developing ear infections and hearing loss. So he's probably going to be sent to an audiologist to make sure that there's no hearing loss. And if there is, that they catch it early. But we don't need the endocrinologist or the cardiologist.
Ralph, why the orthodontist? Dentist?
Ma'am?
Why the C?
The orthodontist?
The tooth structure.
Because their mouth moves. We've now closed
Their
an
tooth would be
opening.
affected.
So what would be affected?
The teeth.
Yeah. Or the fact that he's only 3 months old and he has probably has no teeth yet. He's going to need that orthodontist early on.
Protection of the teeth.
Yep. A nurse. So let's go back to this. This is a new question. So that's the last question related to our case study. So let's go back and see what type of questions we had. What part of the nursing process we did. So if you picked up throughout, I was having you evaluate the information, right? That's typically how you should be addressing these questions. Make sure you're evaluating as you go along so you know what's going on with the patient. You are also recognizing cues of what's normal and what's abnormal. Whoever's got their mic on, can you please mute it? So we're also looking at what's normal and what's not normal. So we're recognizing those cues. When we got to this slide, we evaluated again what was normal and what was abnormal. Same with our vital signs and our history. We did two things. We recognized the cues of what's normal and abnormal, and then we evaluated it and we compared. This question, we were recognizing the cues of what's going to predispose this patient to the cleft lip and cleft palate. Here we were looking at planning and what could be potential problems. In this one, we were looking at what interventions we were going to do. In this one, again, we were evaluating. And this one, we were again planning and recognizing cues of when this baby can have the surgical repair. These were evaluation. And then this one, we were again looking at recognizing what actions we as the nurse are going to perform, evaluating our lab values in relation to comparing it to the rule of tens to see if he met all the criteria, and then planning home post-op care and then his home care. So you see how those questions go through each step? Is that helpful?
Yes, Prof.
So a nurse is educating a group of nurses on celiac disease. Which of the following are precipitants of a celiac crisis? So select all that apply. I see B, C, and D. So B and C are correct. D, excessive physical activity does not induce or cause a flare up of celiac disease or a celiac attack. B, ingestion of gluten, obviously. Fasting can also cause a flare up because this patient's becoming dehydrated and malnourished and can cause a flare up. An infection can cause a flare up. Increased fiber intake doesn't necessarily precipitate it, as long as they're eating non-gluten fiber. So that's going to be your fruits and your vegetables. So your answer choices
Professor,
are A, B,
so,
and D.
hello, Professor.
A, B, and C. Yes.
So you said the answer will be what?
I just said the answers A, B, and C.
Oh. Okay. Thank you.
Yeah. So when you're looking at the answers, you should also be looking at why the answers are correct and why the other answers are incorrect. Do you see that? Because another question NCLEX may ask you, they may turn this question around and ask you for an incorrect answer, or would say what does not precipitate, or something to that effect. A nurse is educating a teenager with celiac disease on an appropriate diet. Which of the following foods should the client be encouraged to avoid?
A, C, and D.
Correct. A, C, and D. They can have products made with cornmeal, and they can have rice and rice products. So, puffed rice would be like your rice cakes. Some of your flavored rice cakes you need to be careful with and educate them to read the label, because some of them may have some gluten in the flavorings as well. The malted milk contains that barley. The crackers are made of gluten, and as well as pasta. Most pastas are made of flour. A nurse is planning a staff education program about
Yes,
celiac
that's what
disease.
I'm trying
Which of
to
the following information should the nurse include? I don't know why it keeps doing that. What do y'all? I'm not able to go back to the chat. What do y'all think is the correct answer?
D.
D.
A as an apple.
A as an apple has it. A is the correct answer. Celiac disease is an immune mediated disorder, which is the same as autoimmune disorder, in which the absorption of nutrients is impaired. It is not a autosomal recessive disorder. It can be genetic, but it's not strictly autosomal recessive and it's not strictly genetic. So A is your correct answer. A nurse is educating the caregiver of a child with lactose intolerance. Which of the following nutrients should be supplemented in the child's diet?
Isn't that all that apply?
I'm sorry, which ones?
Vitamin C and D.
Okay.
And calcium too.
Iron, calcium.
Iron have in there.
Vitamin C, calcium, and iron.
Vitamin C, calcium, and iron.
Okay.
Milk contain
D,
the vitamin
calcium,
D,
iron.
calcium.
And iron, C, D, E.
C, D, E. Correct.
Yeah.
So you
I'm not
guys
sure
are kind
about
of
the iron, but I'm sure about D and calcium.
yeah. So go with what you're sure with. The last person who spoke, you said you weren't sure about iron, but you were sure about vitamin D and calcium. So vitamin D and calcium are correct. Iron is not found in dairy products. Most of our products that contain iron are red meats, some of your beans and your legumes, and fortified cereal. Vitamin C is found in our fruits and vegetables. And where's vitamin A found? Vitamin A is in a lot of your
Orange stuff.
Orange, yeah, yellow, orange
Vitamin
fruits and
A
stuff.
found on the
And
green
vegetables.
vegetables.
right. So vitamin A is going to be found in your yellow and orange vegetables. And so like sweet potatoes, carrots, those kind of things.
Pumpkin.
So your answer choice is D. I'm sorry, C and D. Vitamin D and calcium. Because remember, vitamin D and calcium is found in your dairy products. A nurse is educating the caregiver of an infant diagnosed with lactose intolerance. Which of the following foods should be avoided? Again, it's a select all that apply.
Yogurt, cheese, butter.
Yeah. A, D, E.
Yes, A, D, and E. Yogurt, cheese, and butter. Those are your dairy products. Most often, those are all processed dairy products, which is where the lactose comes. Well, it doesn't necessarily come in, but it's dairy products. Soy and almond milk do not contain lactose. They're not
Plant-based, yeah.
do what?
Plant-based. Plant-based or soil
Yes,
and
they are plant-based. A nurse is caring for an infant scheduled for pyloromyotomy within the next hour.
Oh, caloric surgery.
I'm sorry? Which of the following actions should the nurse prioritize?
Complete and document through the preoperative assessment.
Antibiotics. And
B.
it's B. Administer pre-operative antibiotics.
So remember, this is a priority question. So all your answer choices are going to or could potentially be correct. So which one is the best answer choice out of all of those?
We need to complete the assessment first.
C.
D as in
D.
dog.
D.
So D is the correct answer.
Complete and document a thorough pre-operative assessment.
D.
So I don't necessarily agree with that.
B. Administer pre-operative antibiotics.
I don't agree with that either.
A,
Let's talk
it's
about
A.
It's
Because
C.
the infant
C.
cannot
talk
eat.
about
for
this.
alpha.
Okay, let's talk about it for a minute. There's a couple of cues in the stem of the question. So the patient is going for a procedure, a surgical procedure, within the next hour. So
Oh yeah, nil per oral.
do what?
Please relax.
A.
I mean nil per oral.
A.
C.
Yes.
Yeah, A.
It's A. We want to verify that this baby has had nothing to eat or drink.
Right.
Because they can't go to surgery if they've had anything to eat or drink. Remember, priority means what is the best answer choice? What is going to keep this patient the safest? So, administering preoperative antibiotics is ordered.
That can give an OT.
We can do that at any
In
point within
OT.
that hour. Ensure the infant's identification.
Can you guys please let the instructor talk? Some of us want to listen. You guys cannot be interrupting her.
Ensure the infant's identification bands are correctly in place. Well, we're going to do that multiple times before we take this patient to the operating room, right? And complete and document a thorough preoperative assessment. Yeah, we're going to do that too, but part of that assessment is making sure that this patient has had nothing to eat or drink for the allotted 6 hours. Does everybody see that? Okay. This is another case study, and again, it's going to go through those same 6 questions or different questions that are going through the nursing process. So I tell students as you're going through it, do the evaluation kind of like we did with the previous one. So a nurse in the pediatric unit is caring for a 5-week-old male client. The client is brought to the emergency department by parents due to persistent vomiting. Parents report that for the past 2 weeks, the infant has had progressive projectile vomiting after each feeding. The vomit is non-bilious and milk colored. The baby appears hungry and irritable after vomiting and wants to feed again. Parents also note a decrease in wet diapers over the past few days. So, body systems and the findings. Respiratory has vesicular breath sounds bilaterally. GI wise, the abdomen is soft, mild distension, palpable olive shaped mass in the right upper quadrant, and peristaltic wave visible across the abdomen after feeding. Cardiovascular S1 and S2 are heard with no murmurs. Pulses are 2+ regular in all extremities, and the capillary refill is 3 seconds. Neurologically, he's alert but irritable, no focal neurological deficits, and his fontanelles are slightly sunken. Skin-wise, it's cool and dry, decreased skin turgor, and no rashes or lesions. Musculoskeletal-wise, normal movement in all extremities, and no abnormalities noted. So there's a couple things in these findings that would concern me. What concerns you? Anything respiratory-wise?
Palpable liver-shaped mass in the right upper quadrant.
Okay, so we're talking about respiratory right now. Anything respiratory?
No.
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 How about GI-wise?
Yeah.
Yes, there
Palpable
is.
olive-shaped mass in
Slightly
the right upper
distended
column.
abdomen.
And peristaltis or web visible.
Yeah. So all three of those things. His abdomen
Yeah.
is soft. That's what we want. Mild distension is concerning. The mass is concerning. And the peristaltic wave is concerning. How about cardiovascular wise?
Capillary refill 3 seconds.
Capillary refill.
No,
What?
it is 3 seconds. It's normal.
It is normal. Yeah. Neurological wise, what's concerning? What cues do you recognize?
Sunken fontanelles.
Sunken
And
fontanelle.
irritable.
Irritable.
He's irritable.
And
Yes.
fontanelles.
Sunken fontanelles.
What is the
Fontanelle.
sunken font? What is the slightly sunken fontanelle indicative of?
Dehydration.
Dehydration.
Yeah.
Dehydration, yeah.
How about his skin? Anything concerning?
Yeah,
It's dry.
Decreased skin turgor.
Decreased skin turgor.
Dry.
Yep.
And cool and dry.
And there's nothing with muscular skeletal. So anything concerning here?
Blood pressures.
Well, how old is he?
Blood pressure.
Yeah.
Blood pressure.
The blood pressure is very low. The heart rate is
Oh,
high.
he is the
Heart rate.
infant.
And Harry as well.
Heart
Harry.
rate. Which is something that
Yep.
I was concerned.
Yep. So complete the diagram by dragging from the choices below to specify what condition the client is likely experiencing. And then secondly, the actions the nurse should take to address the condition. So let's look at the first one. Place an NG tube for abdominal decompression. What's the potential condition?
Interception.
Intussusception. Yeah. And
Pyloric stenosis.
Pyloric stenosis.
Pyloric stenosis for olive-like mass.
Okay, so we're on the first one. What are we gonna
Professor,
place?
please, can you bring the slide to the center?
What? Let's stick with the first one. Place a nasogastric tube for abdominal decompression. Y'all said the potential condition was intussusception. That is correct, but what parameters are we going to monitor? Your choices are to the right.
Sound. GERD.
We're actually going to monitor urine output.
Yeah, definitely.
So prepare the client for a pyloromyotomy.
Pyloric stenosis.
Pyloric stenosis. And what are we gonna monitor? What parameters?
Abdominal
tenderness.
abdominal grapes.
bowel movement frequency.
So
Pyloric stenosis, we're going to
Bowel
monitor the
movement
serum
Serum
level, serum
electrolytes.
electrolytes.
we're
Yeah, dehydrations.
well, pyloric that we're gonna potential condition is pyloric stenosis.
not
We're actually gonna monitor his stool color because remember the stool can change shape, color, any of it. So
Okay.
it administer esomeprazole as ordered.
GERD.
GERD.
GRD.
And what parameters are we gonna monitor?
abdominal tenderness.
Yep.
Mm-hmm.
Encourage oral rehydration therapy.
Urine output.
That's your disease process. What's your disease process?
Serum electrolyte level. Lactose intolerance.
Intussusception.
No.
Gastroesophageal reflex.
No. That's not.
Don't
I cannot
understand any of
pronounce
this
the very
question.
first one.
Interception.
I cannot pronounce. That is the
Interception.
condition.
Intersuc.
Intersuction.
Bowel movement frequency and serum electrolyte.
Yes, the very first one.
Intussusception was the first one, yes.
Yes.
Encourage oral rehydration is gonna be for
No.
your reflux. I'm sorry.
Reflex?
No, I'm sorry.
No.
I'm looking. It's
Because
for
Bowel movement.
well, no, we're looking for a condition.
yeah, because in that condition we
It's
get dehydrations.
oral rehydration therapy is going to be for your lactose intolerance. Remember,
Yeah.
they can be dehydrated. And what are the parameters that we're going to monitor?
Urine
IOChat.
output.
What?
Right level.
Urine
Intake
output.
and output.
Yes.
Or
Urine
urine output, yeah.
And what about administer IV normal saline as ordered? There's no real
Serum electrolytes.
Maybe for GERD, everyone just look
Pylorus
at the serum electrolyte level.
there's not a condition for the electrolytes, but it could be for dehydration. And what are we going to monitor?
Serum electrolyte level.
Serum
Yes.
electrolytes. Yes.
So we don't have a condition here, right?
No, there's no condition there.
Okay.
I have a question, please.
Yes.
So for the interception, why are we monitoring the urine output?
Because that's one of the your intussusception is the tunneling
telescope
of
telescoping of intestine.
It is the tunneling or the telescoping of the intestines that can cause a blockage and it can cause an obstruction. And we're monitoring urine output as well and abdominal tenderness and urine output.
Okay.
But it's throwing me off because I would have said the current jelly stools and all of that. I'm so confused.
But that wasn't one of the answer choices.
Yes, so it's so confusing for me.
Right. So you have to go with what you have as far as your answer choices. So you'll see here when we get to the pyloric stenosis is your
answer B. Answer D.
B and D.
B and D.
B, D, and E?
Yeah, it's B, D, and E. These patients have an increased appetite because the stomach empties slower due to the obstruction, and it's leading to them being hungry all the time.
Okay.
So that is all I have. Does anybody have any questions?
Yes, Prof. Please, for the last question, what should be the stool like?
This one?
The last question.
This is the last question, or you mean the one before this? This is the last question. The answers are B, D, and E.
Yeah, I want to know the stool. What color should we expect in the type of stool?
For pyloric stenosis, she means.
Yes.
What color stool? I don't know that there's a.
I think
like
she wanna know about the structure of the stool, just like ribbon-like, jelly-like, or
ribbon-like is for intussusception, right?
I mean, I'm just giving example. What are the characteristics of the stools?
For pyloric stenosis?
Yeah.
I don't know that there's just changes in the stool, but the hallmark of pyloric stenosis is what? It's not necessarily related to the stools. What is it related to? The projectile vomiting. Right.
Oh,
right.
Okay. Thank you.
This I don't think there's any abnormalities with the stool. It's more so the hallmark is that projectile vomiting. Anybody else have any questions?
Ma'am, can I talk to you after everybody has left?
I'm sorry?
Do you mind if I talk to you after everybody has left?
No, I can stay on.
Thank you.
Hello, okay, the part, I need clarification on the second to the last question. The condition for that IV esomeprazole, I didn't get it, ma'am.
For this one?
Second to the last question, under
This
IV
one?
esomeprazole, the condition.
There was no condition for the IV. It could be dehydration.
All right, ma'am. Thank you.
Thank you, Professor.
You're welcome.
Thank you.
You're
Thank
welcome.
you so much.
Thank you, ma'am.
You're welcome.
Thank you.
Could you go back to those conditions for me, please?
Can I go back to which one?
I think the one with the potential conditions.
I'm going to have to pull it back up. Give me a second. This one?
Yes.
Okay.
I am lost.
You are lost?
Yes.
Okay. So an NG tube, we're going to put down for the potential condition is going to be intussusception. And we're going to monitor urine output because of that obstruction.
Okay.
Why do we do a pyloromyotomy? What condition do we do that procedure for?
The pyloric stenosis.
Pyloric stenosis, and we're gonna monitor what?
The urine output.
No, we've
tenderness.
already used the urine output.
Abdominal tenderness.
Abdominal tenderness, yes. So administer IV that the esmaprozole is a PPI inhibitor, which is your proton pump inhibitor. And what do we use that for?
GERD.
For any
for GERD.
Yeah. Like if any like internal bleeding or anything like that. No, vomiting. Sorry about that.
To reduce acid production.
We can use it. We do use the pantoprazole for internal bleeding and GI bleeding. The pantoprazole, which is also a proton pump inhibitor, but we typically use them. Your answer choices are to the right, so it would be reflux, the GERD.
Yes.
And what are we gonna monitor?
The GERD.
Well, what is our parameters to monitor?
Bowel movement frequency.
Are the bowel movement frequencies. Rehydration and the normal saline is oral rehydration. And the normal saline is for dehydration, and we're going to monitor electrolytes.
Yes.
I never can see the previous webinars. You need to be a member of NCLEX.
Could you repeat for me, please?
Can I repeat? You need to be a member of NCLEX or subscribe to NCLEX, and it's also seen in previous you find it under previous webinars.
And how do I go about it?
So if you go to the NCLEX website, previous don't let me. Do you subscribe to NCLEX? Are you?
I don't.
Okay. Are you the person who's asking the question? Because I'm
yes.
Okay. So that may be why. Because I'm reading the chat and I'm talking to somebody. There is a subscription to NCLEX to see the videos again. There's a free trial component and then the subscription.
Okay. Thank you very much. Will do.
You're welcome. So I would contact the I subscribe.
Is this the end of the class?
Ma'am?
Is this the end of the class for
yes,
today?
Yes, ma'am. It's the end of the class.
Okay, because
Hi.
it is already 11, so I was just waiting if it is ended.
No, it's ended. I was just answering questions, and somebody asked to speak to me when we were done.
Okay, thank you. Bye bye.
You do so
Whatever.
many times, and they don't answer. Um, give me just a minute.
Yeah, I would like to talk once everybody has left so that we can have personal conversation. Hi, does anybody has anything left to talk?
No, we're done. Somebody wanted to speak to me when we were done.
Yeah, I'm waiting. I see people on the online
Right,
side.
right. For Fermini, can you help answer this person's question? She says she's been trying to contact and nobody's answering. Is there another number or another way for her to contact somebody? Can you please I'm sorry. Yamali, can you message Mr. Fermini in the chat privately? Do you know how to do that? And he can link you to IT directly? Do you know how to do that? So if you go down to the very bottom of the chat, you'll see a space where it says type message here. Okay, he said he'll message on the chat. He'll message you on the chat, so watch for his message. You're welcome.
Um, you know what? I think I'll just speak it to you. Hi, ma'am.
Yes, hi.
So I was recently approached by one of the somebody I don't know in one of the group, and they said to me that you provide NCLEX study guide kind of material to study for the NCLEX.
So Naxlex does that. I don't personally do it. I do it throughout the sessions, but if you subscribe to Naxlex, the tutoring, we also have readiness assessment tests and practice tests that get broken down, and I'm one of the people that makes those videos, and then I do several tutoring sessions a week. This week I actually do 3. My content that I personally teach is childhood illnesses and pharmacology, and they just recently added EKG, and we're on the third tomorrow. I think tomorrow night is the third week of EKG.
Are they doing anything with the maternal and the newborn and
So
fundamental?
some of the other tutors do newborn and maternal child. I don't. I do EKG, pharmacology, and then childhood illnesses.
Is it done in the same page, or do they have a different page?
So each tutor does it or provides information their own teaching style. I can't speak for the other ones.
No. Do they provide the Zoom link?
The
Like in
content
the
is all gonna be the same, like setup. It'll talk about the disease process, the signs and symptoms, the treatment, the diagnostics, how we monitor it, all the kind of things I talked about tonight.
No, I mean to say the Zoom link. Is it on this same page or is it on a different page?
The the Zoom link for the tutoring you're asking about?
Yeah, for the other tutors, yes.
Yeah, all of mine. It's all through here.
And the others will have their own group.
No, it's all through Naxlex.
Okay.
Yeah, so there's two. If you go to the website, you'll see the sessions and what's being taught at the different times. There's 2 sessions per night. I'm on Eastern time, so one is set from 7 to 9 and one is 9 to 11. Tomorrow you'd have to somebody's asking when is the next Zoom. I don't know when the next one is. The next one for I have one tomorrow and I have one Thursday. Tomorrow, let me look. Tomorrow is EKG and I believe it's at 7 o'clock. Yes, tomorrow is EKG for me. There may be one at 9 o'clock, and I don't know what it is. Is EKG from 7 to 9. And then on Thursday, I am 9 to 11 with pharmacology.
So where do I find this information of the classes that we have here? On the NCLEX dashboard?
On the NCLEX website. Yes, ma'am.
So I'm on the website itself and like the information you just told me. Video library. Is it the video live?
You're not seeing that information?
No, I'm new to this, so I'm like trying to learn it.
Okay. I'm trying. So I'm a nurse and computers. I was trying to see if the person was still on. There's typically an IT person on every session, and I see that he's logged off. Oh no, he's here. He's here. Hold on. I'm gonna message him and see if he can help.
And so like do they provide information or teaching for LPN students?
So it's geared for give me just a second. Okay, I just messaged him. So for it is geared for RNs. I don't think at this point they're doing any particular LPNs, but you can still gain the same information.
Yeah, I'm just
on the okay, so he's saying on the menu, check on the tutoring schedule. So go to the menu and then check the tutoring schedule.
Okay, you want me to go to the menu. So I have a dashboard, RN, LPN. Tutoring. Video library, I see.
Yamali, you were asking yes, I see. I just saw that in there. Tomorrow is 7 to 9 EKG. and Thursday is 9 to 11 pharmacology.
I'm not able to find it. So I'm in the NCLEX page, and you want me to go where? You said I see your dashboard settings.
Go under tutoring schedule.
I don't have that here. Let me please.
No, we don't see any. Okay. He's answering some questions, so just give me a minute.
Do they have the readiness test for the LPN students here?
Not necessarily for the LPNs. They're geared towards the RN, but the content could be useful for LPNs as well. Yes. So are you on? Let me see if I can pull it up. Let me go to my other computer and see. I'm not sure why you're not seeing it. If you're on the, let me see if I can pull it up under my other one. Okay, so can you see the menu?
Yeah, the 4 strap lines, right?
I'm logging in on my other computer to see. Hold on.
I'm using for my phone. I don't know if that's the reason.
So on the, if you're, do you subscribe? If you go to Naxlex, naxlex.com, and go to nclex,
I don't have that option. I don't know if it's that the phone that I'm using is like small screen and it's not.
what browser are you on?
Chrome, I guess.
Try Microsoft Edge. Because if I'm on Microsoft Edge, I can see it.
Okay. Yeah, I don't have that.
Are you using the Naxlex nursing version or the Naxlex NCLEX?
It says QBank just like NCLEX RN. The 14 days free subs, unlimited access on all resources.
So go to look in the chat. He just put its app.naxlex.com.
Oh, okay. app dot
app.naxlex.com.
NAXLEX or NEX?
If you look in the chat, he has put it in there.
I'm also not a tech savvy, so I'm like I struggle to maneuver around. So I use next like okay. App, okay, got it here. Okay.
So he's put in there a screenshot in the chat box.
This one, maybe I need to.
Can you see the screenshot in the chat box?
Yes, I did. I just did. I think I need to.
That's the one you have and you can't see nothing. It should.
Okay. Here.
Then it might be something you might need to call IT on.
Okay. Maybe now I'm able to just give me 1 second. Okay, here. So we have this one here. So I'm going to reset QBank here in the menu. So I have readiness assessment, standalone questions, test taking strategy, live tutoring. Is that the one?
I'm sorry. What does it say?
Oh, the tutoring schedule. So earlier I was looking for the. Where do I have the recorded lecture here?
So I don't. They automatically record and they get posted, and they'll be under previous recordings.
Previous webinar.
If you put in the chat your information, if you have an account, they can follow up with IT, because this is kind of beyond. I don't know, and he's trying to help in the chat.
No, that's perfectly fine. Thank you. No, you've been great. Thank you.
I'm sorry.
No, I said that. Thank you so much. I think I'll figure it out now.
Okay.
Thank you so much.
Then you all have a good night.
You too.
Good night.
Good night.